Data tongue cancer surgery. When AI sees what doctors miss, your surgeon thinks they know exactly how your tongue cancer surgery will go. They've done it 100 times. But they're probably missing something that a machine learning algorithm just spotted. Something that will determine whether you spend the next month healing normally or fighting for your life in an ICU. How is artificial intelligence better at predicting who's actually going to get sick than the doctors holding the scalpel? Here's the thing about tongue cancer surgery. It's brutal. Not because surgeons are careless, but because the tongue is aggressively complicated. It's attached to basically everything. Blood vessels everywhere. Nerves that control your ability to eat, speak, swallow. When you remove a tumor, you're removing part of the architecture of your face and mouth, and then you have to rebuild it. That reconstruction, muscle grafts, tissue transfers, microsurgery, carries real risk. Sometimes things go catastrophically wrong. Infections, bleeding, the graft dies, your airway collapses, you end up back in surgery, you end up hospitalized for weeks instead of days. Before this study, surgeons relied on something called the ACS-NSQIP risk calculator. It's a standard tool. It looks at your age, your weight, your smoking history, your medical conditions. It spits out a percentage. 20% chance of complications. 40%. That's what doctors told patients before surgery. But here's the problem. That calculator was designed for general surgery, hip replacements, gallbladder removals, not for the specific nightmare landscape of tongue cancer reconstruction. So a team of researchers decided to build something better, something trained specifically on tongue cancer surgery data, something that could actually see the patterns that matter. This study comes from some serious institutions. Johns Hopkins, Harvard, the National Institutes of Health, published in JAMA Otolaryngology in June of 2026. These weren't casual researchers tinkering in their spare time. This was years of work across multiple countries, US, Germany, Switzerland, all trying to crack the same problem. And they did something most medical AI studies don't do. They didn't just build a model and declare victory. They compared it head-to-head against the existing calculator. That's how you actually know if you've built something better. So what did they do exactly? They grabbed every tongue cancer surgery case from the ACS-NSQIP database between 2008 and 2024. That's over 700 hospitals, mostly in the United States, spanning 16 years of patient data. They found hundreds of cases. Each one had a complete picture, what the patient looked like going in, exactly what surgery they got, what happened in the first 30 days after surgery. Think of it like this. Imagine you're trying to predict which tomatoes will go bad first. You can measure how red they are and how big they are. But if you really want to know which ones will rot, you need to know the temperature they were stored at, the exact variety, how they were picked, when they were picked. You need way more data than eyeballing. That's what machine learning does. The researchers fed these algorithms 31 different pieces of information about each patient. Age, sex, smoking status, BMI, kidney function, liver function, diabetes, heart disease, whether they'd had radiation before, the size of the tumor, whether they'd get a reconstructive flap, whether they'd have other surgeries at the same time. Every detail the algorithm could possibly use to make a prediction. Then they asked it a simple question. Who is going to have major complications in the first 30 days? And here's where it gets interesting. The AI models crushed the existing calculator. The old ACS-NSQIP calculator performed with something called an AUC score of 0.69. That sounds technical, so let me translate. It means it was right about 2/3 of the time, but not that much better than flipping a coin. It would miss people who actually got sick. It would scare people who were actually going to be fine. The machine learning models? AUC of 0.80. That's a measurable jump. Not enormous, but meaningful. In clinical terms, that's the difference between seeing the problem and not seeing it. But here's what actually matters. The AI was significantly better at identifying which patients were genuinely at high risk, the patients most likely to end up back in the OR with an infection or bleeding, the ones who'd need to stay in the hospital an extra week. That's the group you really need to catch. Those are the people whose surgery plan changes if you know what's coming. Let's be specific. There were major complications in somewhere around 30% of patients overall. That's enormous. 1 in 3 people having tongue cancer surgery experienced something serious enough to write about in their medical record. A fever, an infection, a hemorrhage, graft failure. The machine learning model was better at separating the 20% of patients who were actually at severe risk from everyone else. It flagged them earlier. More accurately, what does this mean in someone's actual life? It means if you're scheduled for tongue cancer surgery tomorrow, your surgeon could theoretically run your data through this algorithm, not the guesswork version, an algorithm trained on thousands of cases just like yours from your specific surgery. It could tell you with real confidence whether you're the patient who walks out of the hospital on day 4 or the one who wakes up fighting an infection. Now here's the honest part. This study has limits. It's retrospective, which means researchers looked backward at data that already existed. They didn't actually intervene on anyone. They didn't take the predictions and change anyone's surgery plan and then measure what happened. They just proved the predictions would have been better. That's different from proving that actually using these predictions improves outcomes. Also, the study used the NSQIP database, which is US heavy. Mostly academic hospitals that are probably better resourced than average. So whether these same AI models work just as well in rural hospitals or in different countries, that's still an open question. But zoom out for a second. What's happening here is bigger than tongue cancer surgery. This is a case study in something medicine is just learning to do, building AI tools designed for specific problems instead of generic problems. The old ACS NSQIP calculator was like using a thermometer designed for measuring room temperature to predict whether someone will survive surgery. It sort of works, but it's not built for the job. The machine learning models in this study are thermometers designed specifically for operating rooms. That's the pattern we should expect to see everywhere in medicine going forward. Generic tools getting replaced by specific ones. AI models trained on the exact condition you're treating. Trained on the exact surgery you're doing. Trained in the exact hospital system where you work. The question that haunts this research is the one that always haunts AI in medicine. Will hospitals and surgeons actually use these tools if they exist? Will doctors trust an algorithm over their gut? Will insurance companies demand it? Will patients demand it? Those aren't science questions. Those are human questions. But here's the thing that should actually keep you up at night. Right now, somewhere today, a surgeon is recommending aggressive surgery to a patient they think can handle it. And they might be wrong. The algorithm would have seen the pattern. The algorithm would have flagged that patient as likely to crash. The algorithm exists. It's just not in the operating room yet. Turns out scientists have been busy, and they're not done yet.